So hi everyone, welcome back to the channel. We are currently in quarantine week number 3, and so I decided to wrap up some unfinished business. I promised that I would finish all the neural migrational disorders, and we didn't talk about cortical dysplasia, focal cortical dysplasia in the first part of the talk, so we're going to review that today. And as a special bonus, we're also going to look at other features of epilepsy specimens, including hippocampal sclerosis and granular cell dispersion. So, hope you enjoy it and hope you're keeping safe. So hi everyone, today we're going to be talking about the neuropathology of epilepsy, and this is really a continuation from our neuronal migration disorder talk. We're going to be covering cortical dysplasia and some other common neuropathological features of epilepsy. So this was a presentation I worked on with one of my students, Histochemical. So I want to acknowledge her for all her help in preparing this. So of course, again, this is just for educational purposes and really not meant to be for diagnostic use. We're more interested in the concepts and the theory to help us remember some of these important principles of brain development, neuroanatomy, and neuropathology. So again, we're going to cover some of the most common causes of epilepsy, which are hippocampal sclerosis, granular cell dispersion, and focal cortical dysplasia, which was one of the migration disorders that we did not get to in our previous lecture. So let's first review some of the anatomy of the hippocampus and the dentate gyrus, which are the key structures that are abnormal in this condition. Firstly, hippocampal sclerosis is it's an acquired lesion characterized by neuronal loss and gliosis, and affects the subfields of the cornu ammonis of the hippocampus. And these are really abbreviated as CA1 to 4. So here's the hippocampus here. It's part of the limbic system. It's in the medial aspect of the temporal lobe. And the reason why it gets its name hippocampus is when you resect this structure, you see that at least at the macroscopic level, it resembles the shape of a seahorse, or a hippocampus, as its Latin name is. So in this disease, as we'll see, there's volume loss and sclerosis of this structure, and other terms that you may hear being referred to as Amon's horn sclerosis and mesial temporal sclerosis. So the mesial is really just depicting where the structure is located. It's in the middle aspect of the temporal lobe, and really the Amon's horn aspect is referring to this Egyptian pharaoh that was often depicted with a ram. And you can see that the structure of the hippocampus, these cornu ammonis regions, CA4, CA3, CA2, CA1, form this undulating structure that's very similar to the horn of the of this ram that is beside our pharaoh here, Ammonis, or Amon. So this is where it got its name. Pathologists like to describe things after things that they've encountered in their childhood or food, and this is probably an example of that as well. So this disease in children and young adults manifests as temporal lobe epilepsy, but it's important to note that there is also a similar disease microscopically in elderly, and this usually results from vascular or ischemic insults and certain neurodegenerative conditions that are kind of recently being recognized. So we're not going to talk about the the neurodegenerative aspects of hippocampal sclerosis, and we'll focus on epilepsy. Just kind of paying homage to the pioneers in this field. This was really characterized by a physician or scientist known as Summers. So in the 1800s, by looking at 90 cases of epilepsy, and this CA1 region, which we'll see is the key region affected in hippocampal sclerosis, has been thus named after him. It's called Summers sector. So that's just something of historic value. So granule cell dispersion, it co-occurs with hippocampal sclerosis, and really it's defined by dispersion of the dentate, which is this purple structure shown here, and we'll see more examples of what it looks like when you get this descriptive diagnosis. So here is a section of the brain. It's a coronal section. It's stained with crescel violet or a Nissl stain, which allows you to see the neuronal cells, which are covered here in purple, and then the white matter is free of this dye. So this is the temporal lobe, and what you see here is in the medial aspect or the mesial aspect, you have this very convoluted structure, which is your hippocampus, and you have your dentate gyrus, which is this very dark line here, and then we see these cornu ammonis CA4 is within the dentate gyrus, CA3, CA2, CA1, and then you get into your parahippocampal gyrus, which has the subiculum and the entorhinal cortex, and then you enter your fusiform sulcus or your collateral sulcus into the fusiform gyrus, which is kind of the gyrus that's important for facial recognition, and I guess it's one of the early ones that becomes damaged in Alzheimer's with the hippocampus, so you lose your memory and your ability to recognize familiar faces. So that's really the anatomy of the mesial temporal lobe. Here's a really nice lateral geniculate body, which is the famous Napoleon's hat that you can see macroscopically, just to kind of orient yourself. This is, I put this in here just to understand the microscopic anatomy and the connectivity as well. And this really helps hopefully appreciate why the hippocampus is such an important structure in epilepsy, and some of the patterns we'll see later on. So when the hippocampus is really our structure that helps form us memories, and as we know from high school and undergrad, the way to form memories is by memorizing something, by either writing it out repeatedly or saying it out repeatedly, and that's really what the hippocampus does. Memories that senses that we sense in our somatosensory cortex will be sent to the hippocampus into this entorhinal cortex, which is the kind of entry point from the neocortex into this more primitive archicortex structure. And then from the entorhinal cortex, you have this perforant pathway where neurons here send axons to the dentate gyrus. And you can see here's a neuron of the dentate gyrus. It has these dendrites that accept the axons. They will connect to the CA4 and CA3 neurons, and then they form this pathway here that really go to the CA1 region, this Summers sector. And I think, if I remember correctly, this is called the Schaefer pathway. So as you see, this is CA2. It's completely skipped by this pathway. From CA1, it goes back to the subiculum here, and then into the deeper layers of the entorhinal cortex. So what happens then is it can either go back to the somatosensory regions that sent this signal, or it can loop back into this hippocampal loop and basically help reinforce that memory by creating this loop and communication with the neocortex, allowing for what's called long-term potentiation, so the ability to store memories. And we know that this is the function of the hippocampus, because when the hippocampus is removed, memories formed previously are retained, whereas if you remove both hippocampi, obviously you're not able to form new memories, as we learned from patient HM, the famous patient that taught us what the hippocampus does. It's really solidifies memories and new memories rather than store old ones. So that's really the connectivity, and we'll revisit that again. So I also like to know the embryology of structures, just because it helps put things into perspective. We learned earlier that the majority of the neocortex is formed by these radially migrating neurons that come from the ventricular zone and migrate out to the cortex. One question would be, how are more complex structures like this formed if the majority of neurons are migrating along these radioglial pathways? And really, this is just a nice diagram here that shows you how you would go from this kind of tube-like structure into this highly convoluted structure in a very coordinated and very precise manner. You get this sort of folding and convolution of this neural plate, and you can see the end of it becomes the dentate, and you have your cornua monis, your subiculum, and your I guess parahippocampal gyrus. So or parasubiculum, perhaps. This happens around 15 to 20 weeks. And again, really, you get all these structures formed in this parahippocampal gyrus, and at that point, you can see it on a fetus. So that's good to know in terms of landmarking and dating fetal brains at autopsy. So again, interestingly, it forms in an outside-in pattern with the outer layers forming first. So this is in contrast to the inside-out pattern that we know occurs in the cortex, and you can. Interestingly, kind of a topic of controversy is that even after birth, the hippocampus continues to go to generate new neurons through a process called neurogenesis. It seems that there's about 30% increase in the first 3 months, and then it becomes a lower rate throughout life, and that's somewhat controversial, but a very exciting area of research in the neural stem cell field. So this is how neurogenesis occurs in the dentate. So you have your molecular layer, you have your granular cell layer, and then you have your subgranular zone, which is where these radioglial cells lie. And these form these intermediate progenitor cells, forming neuroblasts, very similar to what we saw in the neural migration video. And then they form these dendritic processes in the molecular layer that accept the perforant pathway from the entorhinal cortex. And you can see here these are mostly glutamate pathways. These are glutamate or excitatory pathways, and they send excitatory pathways to the CA3 neurons and CA4 neurons. And this is one of the reasons why we get what we see through a process called neurotoxicity of excess glutamate, which is the kind of presumed cause of hippocampal sclerosis. So without further ado, let's look at some of the clinical features. So In patients with refractory epilepsy, that means that their epilepsy is unable to be managed by two or more anti-epileptic drugs. 30 to 34% of these patients will have hippocampal sclerosis. Of those, 40 to 50% of hippocampal sclerosis, temporal lobe epilepsy, will also have what's called granular cell dispersion. So these two diseases go hand in hand, or at least pathological findings. The disease is epilepsy. And really how this process occurs, it's thought that there is an initial precipitating event that happens in the first 5 years of life, usually some sort of complex febrile convulsion, some head trauma, a hypoxic episode, an infection of the brain that leads to some insult and perhaps a kind of an isolated epileptogenic event. There's usually a latent period of several years where the patient or the child will continue on without epilepsy, and then all of a sudden the seizures come back in increasing frequency, and again usually cannot be managed by medical treatment alone. So on imaging, what you see is this kind of atrophic hippocampus. So comparing the hippocampi from right to left, you see that this one is extremely atrophic and has this increased density, hyperintensity on T2 weighted signal, which is one of the MRI sequences. So when you see this is very classic for hippocampal sclerosis, and can be diagnosed really on radiology. You can also use EEG or scalp electroencephalograms to really show that there are some interictal discharges coming from this area. Again, just to kind of confirm what we already know, that this is a highly active area that needs to be removed to help reduce the seizures. So again, the treatment is anterior temporal lobe, temporal lobectomy, or removal of the temporal lobe, or hippocampalectomy, which is really removal of the hippocampus, the amygdala, and nearby structures to try to reduce this epileptogenic focus. And patients do quite well with the surgery. 74% will be seizure-free in their first year, and 50% will remain seizure-free for the next 5 years. So really effective surgery for this otherwise medically unresponsive disease. Some things to keep in mind are, of course, the differentials. You can have low-grade gliomas and inflammatory conditions that can also cause refractory epilepsy. So really, that's really our goal when we get these specimens, is to confirm the hippocampal sclerosis, but also rule out other conditions that may be masquerading as a focal, localized epileptogenic focus. So macroscopically, again, what we see, this is an autopsy, obviously, so this is not a surgical specimen, but when you compare the hippocampi, what you see is this one is substantially smaller than this, than the right side, here we see some enlarging of the ventricular system, where it's not seen here. This is one of the inferior horns of the left lateral ventricle. So those are really the findings. This is more of a surgical specimen that you would expect. Again, you see this collateral sulcus. You see the fusiform gyrus here, the parahippocampal gyrus, and you see a nice beefy hippocampus here, and here's a patient with hippocampal sclerosis, and it's completely atrophied, it's discolored, so that really is the macroscopic finding of this disease. It's important to understand the anatomy, so when you gross these, you do it in a correctly oriented manner, because you'll have difficulty finding the cornu ammonis structures and the dentate if these are grossed in an incorrect orientation. So microscopically, you can stain these sections, and just something to note, a nice learning point is that you'll quickly see this LFB stain here, um, which stains again myelin. It's a chemical that stains lipid bilayers. So things like white matter that are rich in myelin or fatty substances will stain blue, and you can see here, unlike the cortex where the white matter is the neocortex where the white matter is beneath the gray matter, in the limbic system you have almost this inverse pattern where you have white matter on the outside and the neuronal elements on the inside. So whenever you see that, you're probably in a more kind of primitive archicortex region of the brain. So here we have our dentate. Again, the crescent violet is staining the neurons, and then you have your CA4, your CA3, your CA2, your CA1 subiculum, and then going on into the entorhinal cortex. So the perforin pathway is coming through here. It's perforating through this structure. So here again, you see it very nicely in this H&E LFP stain section. What you can see here is you don't see the neurons of the CA4 and CA3 quite well. You see some resistant layer here, which is the CA2, and then again, complete loss of neurons in CA1, and they start coming back here in the subiculum. So that's the classic pattern. This is what you normally see. You see pyramidal cell neuronal loss and gliosis in CA1, usually more prominent in CA3, CA4, and really CA2 is resistant to this neuronal loss. And again, as we saw, that's because it's not part of the circuit that we discussed, from the entorhinal cortex to the dentate to the CA4, CA3 neurons to the CA1 through the Schaefer pathway to the summer sector, and then back out to the entorhinal cortex. So because of it's not part of this excitatory glutamate-rich pathway that can cause excitotoxicity, these are thought to be relatively resistant to this process. So you will see that there's a sharp interface between CA1 and CA2 and the subiculum on the other side because of this. Other things that you may see is corpora malacia, which are these very well-defined circular structures. Here they're stained with a PAS stain, and really they contain polyglycans and other sort of waste products, and commonly seen in epilepsy. So if you see those, not to worry, they're not some sort of organism or tumor. These are highly expected in epilepsy specimens. I believe they're kind of accumulations in astrocytes, and we'll leave it at that. Other things that you may see that may surprise you are areas of necrosis. Here we have some necrotic brain. Here's some where you have gliosis. You have this collection of macrophages, which is a necrotic area. You may have a granulation tissue and a neovascularization. When you see this, you want to make sure you go back to the clinical history and make sure there was no electrodes placed in this patient prior to surgery. They usually put some of these electrodes to better map which areas are part of the epileptogenic focus, so they can minimize a resection of normal areas that are not contributing to the epileptogenic components. You can grade the extent of hippocampal sclerosis. There was a task force, the International League Against Epilepsy, ILAE, that in 2013 came up with this grading scheme. This is mostly kind of more for research and scientific investigation. It's not clear what the actual clinical benefit is yet, but there are some correlations that we'll see. So GFAP is a marker of gliosis, and you can see here what you see is you see a kind of a corresponding increase in gliosis in CA1, less in CA4 in the subiculum and CA2, again corresponding to where you have neuronal loss. Usually when you have neuronal loss, your glial cells, which are the more um, uh, common cells of the nervous system, will come in and populate that area with gliosis and really this is what causes the brain also to become quite firm. This is just showing you the sharp boundary between the subiculum and the CA1 region, where again the majority of gliosis is going to be where you have neuronal loss. These are really useful for maloriented specimens to try to orient yourself. Um, here's nu-N. So nu-N stains neuronal nuclei, and you can see here on this um, immunohistochemical stain that the number of neurons can vary dramatically in hippocampal sclerosis. So here you have well-populated cornu amonis region. Here you have a substantial reduction, but albeit there are some neurons that appear to remain. And of course, you can have much more severe loss of neurons as shown in this panel here. This is a low power view showing you the dentate. Again, staining with this nu-N antibody. You have loss of neurons in the CA4 regions and then kind of preserved in the CA3, CA2, and even CA1. So we'll see how these are graded shortly. But as you can understand, this is somewhat of interest to pathologists to try to see if we can correlate these patterns to specific clinical outcomes and severity. So this is, again, just another example of that that shows you the different types. So in A, we have type 1 of the International League Against Epilepsy type. And you see here, you see the dentate gyrus and complete loss of neurons in the CA4, CA3 region. We see some resistance and neuronal maintenance in the CA2 region and then loss again in the CA1 and then only to be repopulated very nicely in the subiculum. So that's your type 1. In type 2, we see the dentate again. We see CA4, CA3 neurons preserve CA2 as expected, and then very isolated loss of CA1. And then as we go to type 3, really even less severe, affects only the CA4 region, whereas CA3, CA2, CA1 appear well intact. And this is what the normal hippocampus should look like with just mild gliosis. This is a nice cartoon and summary table of this classification. Again, really what we already went through. There's again various groups trying to classify this. But we'll only focus on the ILAE classification. This is your normal hippocampus, or not normal, but if someone's having surgery, there's obviously some abnormality, but in this way it would be indistinguishable from normal, where you have complete preservation of the neurons and no gliosis. When you get this in a temporal lobe epilepsy, this is quite concerning. As you see, patients actually do quite poorly. And it's really because it's kind of counterintuitive, but actually the more severe the lesion is, the more sure you are that this is the cause of the epilepsy and not some other cryptic lesion that you haven't discovered yet. So this is why, at least in epilepsy, the more severe the finding, the better the patients do, because you're actually addressing the problem at hand. So in gliosis only, you have some gliosis here in the subgranular zone. It's unclear how common this is. I've never seen it, to be quite honest. And again, it's unclear if this is even specific for temporal lobe epilepsy. So it may be a non-specific finding, where the patient has another cause of epilepsy that is yet to be revealed. Type 3, where you have CA4 loss only. Again, this is quite rare. I don't see these too often in my practice. And folium sclerosis, so you have neuronal loss and gliosis really confined to CA4. And again, this is often seen when there's another lesion like a DNET or cavernoma, which is a kind of vascular lesion. And that's probably why we don't see them that much, because when patients have these other tumors, if we can identify them on radiology, the surgery is really focused on resecting these other lesions. And again, when you see these poor surgical seizure-free outcome, either because the lesion is also causing some other issues in other areas of the brain, or also, again, you may have not fully resected the cause of the epilepsy. So type 2 and type 1 are more common, 5 to 10%, and then 60 to 80%. Type 2 again is CA1 predominant. I see this quite often, to be honest. And then the classic one is where you do lose CA1, but you also have some loss in CA4 and CA3, and that's fair. That is quite common. You can see here they're trying to depict granular cell dispersion, which we'll get to shortly, and this is the majority of cases, and I think that's a fair statement based on what I see. As you can see here, highest rate of seizure freedom, 70 to 80%. Will be free of seizures after 2 years, and 50% at 10 years. So when you see these things, you know that this is likely causing this is the epileptogenic focus. So removing it is of extreme value to the patient. Let's briefly talk about granular cell dispersion. Again, this is a pathology that's commonly co-occurs with hippocampal sclerosis. And loss of neurons in the cornua manus. Here is you get blurring of the outer border of the cellular layer with the molecular layer, which is this outer layer here. In this case, we have duplication. This is a low power view of the dentate. You have loss of well-defined basal cell layer, and also you have expansion of the granular cell layer from its typical 120 microns to 400 microns. So here we have duplication. This is what a normal dentate thickness should look like. Here we have a duplication where these kind of migrated into the molecular layer. This is a much more homogeneous dispersion, again much more thicker in this kind of 400 micron region, and then here you just have a few cells that have kind of migrated to the molecular layer. And it's really thought again that this is due to stimulation of the neurons in the subgranular cell layer, these neural precursors that produce new neurons that have migrated into this molecular layer, which is where the input's coming from the entorhinal cortex. Here's some more nice images, again just highlighting the tight short width of the normal granular cells of the dentate gyrus. The molecular layer is shown here, and then you can see here this becomes much more blurry and fuzzy and expanded, and you can have different variations with these clusters or these duplications of the band. So again, you can look for this and describe it, and again the goal here is to identify a lesion that could be causing epilepsy, but by describing these different features, perhaps we'll be able to use some informatics and bioinformatics and statistics to see if they correlate with any other interesting outcome. So again, the pathogenesis, we've kind of gone over some of these. The hippocampus is a very well-connected circuit, as we saw, that can serve as loops for propagation and spread of abnormal electrical activity in this kind of circuit that we saw. Usually begins with an initial insult that primes an immature susceptible hippocampus early in life to become a kind of seizure focus, and eventually becomes sclerotic and continues it's abnormal firing. And again, it's largely considered a sporadic disorder, so not something you pass on to your children. So granular cell dispersion, the presumed mechanism, as we discussed, is due to these activation by these radial glial cells with glutamate. So that's very interesting. So glutamate is even in this undifferentiated state, which is something I investigated in my PhD, that these undifferentiated cells are in fact primed to respond to neurotransmitters. And perhaps this may explain the stimulation and activation of glial cells and migration into the molecular layer. In terms of future diagnostics and therapy, as we said, there's interest to see if we can prevent formation of hippocampal sclerosis, because once it's formed, it seems to become a very powerful focus for epileptogenic activity. Perhaps are there any genetic predispositions? So even though it's a sporadic disorder that requires a environmental insult or sort of insult in general, there may be some genetic predispositions that make some people more vulnerable to this process. And again, the real goal of doing all this grading and classification into these various subtypes is to see if they have some prognostic value. And these are, of course, very difficult to do qualitatively, so perhaps it's an area where digital pathology and AI are going to be able to quantify these much better than humans. So let's move on to the second part of the talk, which is focal cortical dysplasia. This is a localized area of the cortex where there's a maldevelopment and varial patterns of dyslamination, dysmorphic neurons, giant neurons, and balloon cells. So pathophysiologically, it's thought to be due to developmental anomaly of migration or post-migratory maturation, or both. As we saw again, neural migration is caused by radial migrating pyramidal cells and tangentially migrating GABAergic cells, and defects in this process are thought to lead to a number of developmental disorders that we discussed, and one of them is cortical dysplasia. This is a much more focal abnormality, so it seems that there's a focal mutation, as we'll see, that may cause a very localized abnormality. So again, it's considered sporadic, mainly sporadic, but there are some rare familial cases, and there does seem to be some overlap with some other conditions that we'll talk about in future lectures that are abnormalities of the mTOR signaling pathway that's implicated in tubular sclerosis and hemimegaencephaly. Interestingly, this sporadic condition has been reported to have these mutations in mTOR. So it's likely that there are some similarities going on, but at least in the focal cortical dysplasia, the anomalies are much more focal because it's a somatic mutation in perhaps one region of the brain that's causing this disease. Again, the International League Against Epilepsy intervened to try to subtype these for, again, research purposes, but there's a long history of trying to subtype these, and there's a special type, as we'll see, which is called focal cortical dysplasia type 2B, which contains balloon cells, and really was described by Taylor in 1971. So clinically, again, it presents with intractable, disabling epilepsy starting in the first decade of life. That's poorly responsive again to antiepileptics. So if you have two antiepileptics and you don't do well, because you have refractory seizures or epilepsy at that point, and that's when this can become a consideration. MRI, you have mild cortical thickening, so you can see here this is much thicker than the rest of the cortex. So you have this thickening of the cortex, and then you have this hyperintensity on this T2 weighted image stemming from the abnormality, and you see it goes all the way to the ventricle. And this is why it's hypothesized to be a abnormality of neural migration, as we'll see. If you look microscopically at this area of hyperintensity, you'll see that there are the abnormal cells that are classic for this condition can be found in kind of a gradient manner all the way to the ventricle sometimes. So again, once you see this, it's very classic, and you can use EEG again to map the exact location to try to limit how much of the cortical region you want to remove to avoid any unneeded disabilities in the children that get these surgeries. So again, anti-epileptics, if those don't work, you need to move on to surgical resection, and as we'll see, the prognosis is variable, but is overall quite good. 60% are seizure-free by 1 year, and again, things improve when there is a complete resection or it's in the temporal lobe. And usually, sometimes, depending on the location, it may be much more difficult to resect than other locations. So just something to keep in mind. So the frequency, again, it's probably the most frequent lesion of epilepsy in children, about 40 to 50%. But if you see this in an adult, you obviously want to make sure that other things that are more common on the differential are excluded, including hippocampal sclerosis, as we've talked about, or a tumor that causes seizures. So all tumors can cause seizures, so you need to have a wide differential, but there are some more common tumors that should be considered in someone with epilepsy. Again, the type 2, as we'll see, is a very special type. It's more reliably resolved on imaging, and focal cortical dysplasia type 2 is really found across the entire brain. More in the frontal lobe. The frontal lobe is, by definition, the biggest lobe in the brain, so it could be just a kind of a complete random localization of these lesions, just depending on how much volume and surface area you have. But they do seem quite more common in the frontal lobe for whatever reason. So macroscopically, you see, you get these specimens. You have these very abnormal broadened cortical tissue that look quite abnormal. And then when you section it, you may see kind of this sharp expansion of the cortical region. In some areas, it may be hard to define borders between the white matter and the gray matter. It feels firm, and again, these have different types. Focal cortical dysplasia type 3, as we'll see, is one where it's associated with other lesions. So it can be associated with tumors or vascular abnormalities or infarcts. So when you see this kind of dual pathology, it falls into the ILAE type 3 FCD. This microscopic picture is, we're going to see lots of examples, but really highlighting these abnormal, dysmorphic, and large neurons that can be seen in the type 2 focal cortical dysplasias. So here is the kind of grading pattern. There's three main types of subtypes of focal cortical dysplasias. Type 1 is really the more mild form, and is quite controversial in terms of how reliable different pathologists are at calling this. You have your type 1A, which is really presents with um, uh, abnormalities in radial dyslamination. And this is an example, you can see that here at least, where you have these very, very long tracts of large pyramidal cells. This is highly abnormal. You do expect these microcolumns to form in the brain, but um, you don't expect them to be that pronounced. So that's type 1. Again, as you can see, I'm kind of being very qualitative, and that's because these are very, very difficult to really objectively call in many cases. So type 1b is really when you have abnormalities in tangential migration instead of radial migration, and you kind of get these strange patterns where you don't see nice kind of reproducible layers. And then you could have a combination of abnormalities of radial and tangential dyslamination for type 1C. Type 2A and type 2B are really the more objective types that can be easily reproducibly called by pathologists. And these are characterized by those abnormal neurons that we saw in addition to this dyslamination pattern. But type A do not have balloon cells, whereas the type B have these classic Taylor type balloon cells, as we'll see. And because these are objective things that are easy to call, again, once we find the lesion, we're quite certain that that's the underlying cause of the epilepsy, and patients do quite well when you see and resect these lesions. ILAE3, this is really just type 1 with another pathology. So type 3A is when you see hippocampal sclerosis being found in the same specimen. You can have epilepsy-related tumors such as DNETs. Gangliomas are kind of the more common types. So that would be type 3B. Vascular malformation such as a Sturge-Weber would be a type 3C, for example, or cavernoma. And then type 3D is when there's some traumatic ischemic event during early childhood that's associated with these patterns. So the old system was Palmini. It was very, very similar, especially with regards to type 2, but that's fallen out of favor, so we won't discuss that today. You can see with nu-n, this becomes quite easy and more objective. So if you're struggling with one of the lesser objective ones, a nu-n can show you a nice kind of layering of the cortex, whereas in perhaps type 1A, you get these very exaggerated microcolumns where you have these large pyramidal cells extending for the full thickness of the cortex. This is just a rehash of that table. Again, just giving you some more objective measures. So there's exaggerated neuronal layering in focal cortical dysplasia type 1. And if you see, you can use 8 as a kind of measure. When you see 8 or more neurons clustering in a kind of microcolumn, that's concerning that this is a type 1A. When those 8 neuronal clusters are have this sort of tangential orientation with the brain's surface, or when you're lacking layers 2 and 4, which are your granular cell layers that come from the tangential migration, this would be a type 1B, and when you see both of those, you have a type 1C. Focal cortical dysplasias, type 2 again, you see these large dysmorphic neurons in addition to this dyslamination pattern. They're irregular, they're enlarged, they're maloriented, they have abnormal nissl substance, and can co-occur with balloon cells in type 2B. In type C, again, as we discussed, it's really focal cortical dysplasias that are associated with other pathologies, hippocampal sclerosis, epilepsy-related tumors, vascular malformations, or kind of early trauma or CNS infections. Here are some H&E images, again highlighting these very odd and large neurons. These are known as dysmorphic neurons. They have a lot of Nissl substance in their cytoplasm, and again, they're large, they're maloriented, and when you see them, it's hard to not to not immediately bring this on your differential. Here is another H&E showing these balloon cells. These are kind of large globoid cells that have this glassy cytoplasm. They're often binucleated. I don't see some here, but this would be an example of a type 2B focal cortical dysplasia. Here's another example to really highlight these abnormalities. Here are these large neurons. They're very abnormal. They have no real pattern to them. There are too many of them. Here is the gross section of that, showing you a control brain with a very nice, sharp cortical white matter junction, compared to this specimen where this is enlarged. It's blurry. There's no clear border between gray and white matter. So this would be highly suspicious on macroscopic exam of this cortical dysplasia. So here's an example of a dysmorphic neuron. You have this Nissl substance accumulating in the cytoplasm, which is abnormal, and then you get these. Here's a binucleated balloon cell. Here's another balloon cell, has this very pinkish, glassy cytoplasm. So again, focal cortical dysplasia, type 2B, Taylor type. In terms of histochemistry, there's a lot of useful things you can do. You can do a Nissl stain or a Crescel violet. These are the kind of synonymous, and really these highlight the dysmorphic and abnormal arrangement of neurons in the sections. So again, this would be these very prominent radial dyslamination patterns of these pyramidal cells. Neurofilament is another stain you can do. This should really be in the axons of the neurons. It's a structural protein, as its name suggests, and when they accumulate like this in the neuronal cell body, it's quite abnormal, and it really highlights the enlarged and abnormal clustering of these neurons. Here you see prominent Nissl substance, which again is a feature of these dysmorphic neurons. There's too much of it. It's not just in this apex here. It's found throughout. So when you see that, these would qualify as dysmorphic neurons. Here's a balloon cell, perhaps. So other things you can do, we talked about NUN to highlight your dysmorphic and dyslamination of neurons, your neuronal loss, ectopic neurons in the white matter. GFAP shows gliosis. Neurofilament highlights the cell bodies of the dysmorphic neurons. Other things you can do is use some developmental proteins, such as DCX, which marks this is a protein that we saw involved in neural migration. It should be turned off in mature neurons. CD34 is also a candidate stem cell marker that should not be expressed in mature neurons. SOX2 and nestin, again, stem cell markers that should be lost during maturation, but in fact we see that they're quite prominent and label these balloon cells. So when you see this, again, it suggests that there's some abnormality of maturation. These progenitors or neuroblasts did not differentiate properly. AKT, phosphorylated AKT, this is one of the proteins of the mTOR pathway, and it labels these balloon cells quite nicely, and interestingly, again, it also labels the same balloon cells in tuberous sclerosis. So again, just highlighting the similarities between tuberous sclerosis complex in cortical tubers and focal cortical dysplasias. Here's some other nice images really highlighting what's going on here. So we have this nicely structured cortex here, and then once you get to here, you have a loss of this pattern. We have some kind of prominent arrangement here. and some neurons in the white matter. So obviously low power, hard to see what's going on, but there's definitely a disruption in the pattern at these arrows that are highlighting this. If we zoom in, if we see these neurons, we know that this is the abnormal component of the cortex, where they're too large and too disorganized and too cluttered to be any sort of normal cortical tissue. And again, neurofilament highlighting the cell bodies of these cells, which is abnormal. You should just see them in the kind of neuronal processes. Myelin basic protein can show loss in the white matter, which would be normal. Nestin, again, is a stem cell marker highlighting the balloon cells, CD34 and connexin 43 also can be used to highlight these. But these are really things that you can see on H&E very, very nicely. So these are more confirmatory rather than mandatory stains. And really most of these, some of these at least, Nestin and connexin 43 may not be available in most laboratories. So don't feel you need to do these to make these diagnoses. We need to also talk about mild malformations of cortical development. These are much more controversial, and really there's two types, with excess neurons in type 1 being in the molecular layer, or layer 1. There's really no precise criteria for this yet. And in type 2, the excess neurons and clusters are found in the white matter below the neocortex. So you can use nu-n and you can count to see how many abnormal neurons you get in a high power field or in a millimeter cubed. And there's cutoffs that have been designated to make these calls. Again, in my opinion, these are somewhat controversial, simply because it's very, very difficult to for multiple pathologists to make these calls. Some may overcall it because they're trying to find a diagnosis to help the patient, but in fact, because they're so somewhat subjective, they don't correlate too well or as nicely with response to surgery as some more objective lesions, such as focal cortical dysplasia type 2. There's other things that you may see that are a result of epilepsy rather than the cause, such as excess oligodendroglial cells or a process called oligodendrogliosis. So these don't meet the criteria for mild malformation of cortical development. And again, these are, I think, diseases that will benefit from things like AI, where these can be objectively measured and perhaps done on a large scale to see if they correlate with any disease. So differential diagnosis of focal cortical dysplasias. There's gangliogliomas and DNETs. These are tumors that are benign. They're not benign. There's no such thing as a benign brain tumor, but they're low-grade lesions. They're WHO grade 1. And if you resect them, patients do quite well. They don't recur. And usually their epilepsy goes away. And you can see why they're on the differential. This is a ganglioglioma with these very abnormally looking, sometimes binucleated neurons, and this is a DNET with these myxoid cysts containing these so-called floating neurons. So these are very common lesions that cause epilepsy. So they're very important to consider and rule out while you're going through these specimens. You want to rule out an infiltrating glioma. Usually these in the younger population that are peripheral are IDH mutated, so using antibodies such as the IDH1 R132H can readily identify it if you're not sure if it's subtle. Again, the major differential is tuberous sclerosis, just because the lesions look very similar to cortical tubers, but this is actually very easy to differentiate simply based on clinical history. Usually patients with tuberous sclerosis have multiple lesions, multiple cortical tubers. They have what are called SEGAs or subependymal giant cell astrocytomas. These are, again, WHO grade 1 tumors. And these patients should also have a number of other stigmata of tuberous sclerosis complex in various organs. So if you have clinical history, you should be able to differentiate a cortical tuber from a focal cortical dysplasia. In hemimegaencephaly, again, they can look very similar. These are, again, all based on this tuberosclerosis complex and mTOR pathway. So this is not surprising that they look somewhat similar, but in hemimegaencephaly, you get an enlargement of the entire hemisphere rather than just a focal area, as FCD would imply. So that's the end. Thank you for listening. I want to give your attention to this lovely book that was used to create this presentation. Thanks for listening. I just want to note, say thank you to the Instructional Technology Innovation from University of Toronto. That's really helped fund this online educational resource. We hope you like it, and really the goal is to provide subspecialty lectures like this in a platform like YouTube to help get it out to more people that may not have access to sufficient teaching in neuropathology and other related fields. So thanks for watching, and I hope that was informative. So that concludes our video today. I hope you learned something about neurobiology, about neurodevelopment, and some of the lesions that we see as neuropathologists, and hope to catch you at the next one. Stay safe, stay isolated, but stay engaged with our channel. Visiting us for the first time, welcome. Please like and subscribe and click the notification button, because we have a lot more content coming to you each week to help increase your neuropsych IQ. See you at the next one.